Next speaker, which I did introduce for our mobile consult service panel, but I will briefly introduce Dr. Ely again. She is a psychiatrist extraordinaire from UCSF and part of our mobile service consult team. And Dr. Ely, where are you here somewhere? Here you are. Currently the director of the Community Consultation Program in the Division of Child and Adolescent Psychiatry at UCSF, and the interim medical director of the Division of Infant, Child, and Adolescent Psychiatry at San Francisco General Hospital. And today she is going to talk to us, it's a long title here, but it's Psychopharmacology for Anxiety and Stress-Related Behavioral Dysregulation in Neurodevelopmental Disorders. Dr. Ely, thank you.
Thank you. Well, thank you for having me again and for that introduction. And yes, the title is long because I wanted to be sure that everyone was clear about what it is that we're going to be talking about. And that it is a mouthful, but it does kind of encapsulate the extent to which these disorders take up a lot of time and space in terms of our patients and our families and the people who take care of them. Anxiety disorders are really important, especially when we include stress-related disorders. And I'll go through how we're distinguishing those momentarily. So I still don't have anything to disclose. And so in terms of our overview, what's I think the most important piece to this presentation might be is that anxiety symptoms as well as fear responses often go unrecognized. These are internal states, and often when individuals finally come to clinical attention, it's because these symptoms have gotten to be quite severe. And when we talk about internal states, we use that term to distinguish from externalizing behaviors, so things that we typically think about when we are thinking about outbursts or tantrums or dysregulated behavior. And so the issues are complicated in that, again, these symptoms are internal. And so clinicians tend to be unaccustomed to even considering these symptoms in the setting of neurodevelopmental disorders. Again, they're not obvious, and so they tend to go unrecognized. And then when and if they are recognized, then we are also facing this issue of diagnostic overshadowing, which means these symptoms basically get attributed to the neurodevelopmental disorder. They're not seen as something different or separate from the neurodevelopmental disorder. And then even more important, I think, than this clarification of the symptoms is the idea that when these symptoms go unrecognized, they cause a great deal of suffering. And related to that suffering is morbidity that is unnecessary because these symptoms can be treated. And hence the third point, effective treatment does exist, and so that will be the focus of my presentation today. I wanted to highlight the fact that even though my title is focused on the pharmacologic interventions, I also want to highlight the fact that there are non-pharmacologic interventions, and I'll actually touch on a few of those toward the end of my presentation. So the learning objectives that I included here are pretty concrete. I acknowledge that. So it's about numbers. But more importantly, I think instead of focusing on the concrete learning objectives, if we think about the more abstract idea that In neurodevelopmental disorders, there often is a lot of anxiety. Some of our local experts here at UCSF and Stanford and Davis suggest that anxiety is basically part of the diathesis, at least in terms of autism spectrum disorders, and that we might even think about some of the symptoms of autism as being on the spectrum of anxiety disorders. Again, this is personal communication, this is their opinion, but I thought it was an interesting point that I thought I should transmit to this audience as well. So that's the more abstract objective, that anxiety disorders and symptoms are quite prevalent, and it's really important to be able to identify them and then treat them. So I've been talking around anxiety symptoms, and so here I am actually going to go into more detail. So as I mentioned just a moment ago, they're considered prominent features of autism spectrum disorders, and likely neurodevelopmental disorders writ large as well. And many studies have suggested that anxiety disorder, not just symptoms, but a comorbid anxiety disorder is present in roughly 40% of individuals with autism spectrum disorders. And we consider them separate disorders because the anxiety symptoms, not the autism symptoms, but the anxiety symptoms are the ones that interfere with daily functioning and that cause impairment or distress. And these symptoms, these distressing or interfering symptoms, include a number of items on this list. So the need for perfectionism, for doing things just so, and not tolerating things that are not perfect, things that are not lined up the way they had them, or things that are suddenly in a different place from where they were left. Additionally, there's the reassurance seeking. That's less distressing for the patient or the subject, and perhaps more an issue for the person caring for the individual. Then there are issues around perseveration, as well as rumination. So perseveration is, we can think of it as more of the behavioral issues, doing things over and over again or wanting to do things over and over again. Rumination is more of the thinking version of perseveration. And then resistance to change. So people think about resistance to change as something quintessentially autistic. But for kids who are anxious, not having change is actually very anxiety binding. It helps to mitigate anxiety symptoms. So that's why these symptoms sound very similar. The idea of change is very anxiety provoking for lots of kids. And then particularly in the setting of autism spectrum disorders. And I just wanted to describe a representative anxiety disorder. This is what comes to clinical attention a lot, and those are specific phobias. So, and again, this is just one of the many anxiety disorders that exist, but it's one that we often ask to intervene about. So the definition of a specific phobia is a fear, and sometimes an anxiety, that's triggered by a singular event, a situation, an object, and it often develops after a traumatic event. So kids who are afraid of dogs have often had an encounter with a dog that was very distressing or frightening, and that event is not necessarily remembered. Nor is it necessarily in the caregiver's awareness, right? So the child may have had an encounter with a dog that the caregiver didn't know about, and so this dog phobia seems to come out of nowhere, but in reality it could represent a traumatic experience with a dog that the caregiver was not aware of. And there are thought to be temperamental risk factors associated with the development of specific phobia. So kids who tend to be more inhibited, more shy, seem to be at greater risk for specific phobia. So again, this is just one representative anxiety disorder. There are others, such as generalized anxiety disorder, but I chose this one as the representative, again, because it presents so commonly in our population. So then I also want to focus a little bit on trauma and stress-related disorders. I was glad that so many of our speakers today have emphasized trauma, because it is so important in every kid that we encounter, every individual that we encounter. We just don't think about it often enough. And in my clinical experience, we don't pay enough attention to trauma. And again, not just the trauma of a singular event, a natural disaster or the death of a parent, but those what we would consider little traumas, the adverse childhood experiences, those traumas that add up, and the cumulative effect is very traumatic, and they have a significant impact during development. And so I'm not talking necessarily about what we classically would call PTSD, but I'm focusing more on what child psychiatrists tend to think about, which is the developmental trauma disorder. And again, in this situation, in this disorder, we're talking about stressors or trauma that can be of many forms. And I want to highlight that neglect is actually considered the most traumatic trauma, at least in terms of the experts in the field. And we today have spoken about adverse childhood experiences, or ACEs, and there are several. And one of these things is bad enough. One of the things listed here, like abuse of all sorts, and witnessing domestic violence, incarceration, again, the issue of neglect. But you have a series of these stressors, and they can add up to significant impairment, not just psychologically, but physiologically as well. And they can lead to a number of problematic consequences that manifest in terms of behaviors in our patients. So I just want to take a few minutes and talk about the stress reaction, again, because I would assert to this audience that we don't recognize this often enough, and that I think we need to think about it more. So I wanted to take a few minutes and highlight this, and talk about the stress reaction in response to fear, and that humans have a stress reaction. When we tend to think about fight or flight, this is what tends to come to mind, right? We recognize that this is a stress reaction, a stress response, a fear response. And so this we're able to recognize, but it's important to remember that humans have a stress response too. It may not be as obvious, and sometimes actually it is, but humans will have dilated pupils, they'll have increased heart rate, increased respiration rate. They may not hiss. Sometimes they do. I've had my share of kids in my office hissing, and they're definitely communicating loud and clear that they are having a stress reaction. And just because I'm showing pictures of critters, it is not meant at all to minimize the significance of a stress response in a human. I very much appreciate that the stress response is a very strong response, just that we tend not to think about it when we think about our human patients. And I'd also like to point out that there's a reason that we have a stress response. It's actually adaptive to feel fear. Fear is a normal response to threat. It's what keeps us alive. This idea of fight or flight or freeze, we don't think about the freezing as much, it supports our survival. There is a reason that this still exists, that we still have this instinct. So it's actually a good thing to have a stress response in terms of things that keep us alive, but there's also the maladaptive consequences of the stress response, and this is where I'm going with this point, that even though a stress response can be healthy, there is a continuum, and on the other end of the continuum, we are talking about a pathologic state. And that the pathology can be manifest in different ways, and whether there's an individual with a neurodevelopmental disability or not, the distress that the fear response generates can have a significant impact on functioning, whether it's social functioning or academic functioning. There is distress and a resulting impairment. And the significance of considering this during development is that this stress response, the pathologic stress response, will have an impact on development in that it will prevent or limit appropriate adaptive behavior. And this is what we are conceptualizing in this term toxic stress. Additional features are the physiologic impact. I'm not going to go into those today, but when you hear about toxic stress, this is what we're referring to. All right, so with that background about anxiety and stress, I'll shift now into what we can do about it. So, not surprisingly, the nature of the distress or the dysfunction will influence our treatment approach. And there are quite a number of interventions. I talked about the pharmacologic and non-pharmacologic. Non-pharmacologic interventions include psychosocial support, somatic interventions like neurofeedback or biofeedback, and psychotherapy as well, as in addition to behavioral therapy. And so I will talk briefly about the latter two treatment approaches. So when we think about pharmacotherapy, we can classify our options into three major classes: the serotonergic agents, adrenergic agents, and neuroleptics. So serotonergic agents you're probably most familiar with. These are things like fluoxetine or Prozac, sertraline or Zoloft, and mirtazapine or Remeron, and venlafaxine, which is Effexor. So these are the medications that affect the levels of serotonin in the synapse. Then there are specific adrenergic agents. I particularly like the adrenergic agents because these are the things that actually target the stress response proper. So the circuitry that underlies our fight or flight reaction. And there are a number of these agents as well. And I'll talk about clonidine and guanfacine. These are things that can be scheduled on a daily basis. Propranolol is your basic beta blocker, and it can be actually a very effective as-needed medication, and it can also be scheduled as well. Prazosin we use when we are concerned about kids having nightmares. And then the neuroleptics, they're otherwise known as the antipsychotic agents. And these are more for behavioral management, so it doesn't specifically target anxiety, but it helps to manage the behavioral outbursts associated with a stress response. So we'll go into a little more detail. The SSRIs, so selective serotonin reuptake inhibitors, do what the name suggests, block the reuptake of serotonin. So when serotonin is released into the synapse, the way that you stop that signal is to clear the synapse of serotonin. And you do that by taking the serotonin back into the presynaptic terminal that released it in the first place. These medications block that process. So the serotonin that was released just hangs around longer, and so it can act on the receptor on the receiving end of the synapse. And these medications are helpful when we treat anxiety in the setting of polypharmacy, so when there are other medications on board, and individuals with neurodevelopmental disorders, and in our experience with CART and with TACT, we often see individuals who are on a slew of medications, whether appropriately or not. That's the reality. And we need to think about an intervention, a pharmacologic intervention that doesn't have problematic drug-drug interactions, and serotonin reuptake inhibitors are such medications. And I'm talking about all polypharmacy. I'm not just talking about psychotropic polypharmacy. I'm talking about lots of polypharmacy. So every medical disorder that can be treated with a pharmacologic agent we need to take into account. It's important to note that all SSRIs are not created equal. In fact, there are generational shifts with SSRIs. The older flavors, fluoxetine or Prozac, paroxetine or Paxil, and fluvoxamine or Luvox, they tend to have more side effects and more drug-drug interactions, relatively speaking, compared to their newer generation. And so we use them more cautiously. They can be very effective, but we just need to keep in mind that they may have more drug interactions. I have to tell you that as a child psychiatrist, we do not prescribe paroxetine. We do not prescribe Paxil for a lot of reasons. But again, it has a lot to do with the fact that it's this older generation drug, and it has way too many side effects for us to be comfortable with. That being said, we can use side effects to our patient's advantage. So side effects aren't always bad. And what that means is that if there's a medication that causes sedation, that's not necessarily a bad thing if anxiety is causing a person to have difficulty sleeping. So we harness that side effect, we schedule the medication for bedtime, and we've managed to use that medication even more effectively than otherwise. So side effects aren't necessarily a bad thing. It's just important to know what they are so that you can use them to your advantage. It's also important to recognize pharmacokinetics and pharmacodynamics. There's a reason that we have to learn these things. And some have shorter half-lives than others, which mean that we need to be careful in terms of dosing. Some drugs just aren't good for once daily dosing, and we need to think about dosing twice a day. And we've talked around side effects, so I'll mention that the most prominent side effects with SSRIs are related to GI disturbance, so lots of tummy aches, some people get constipated, some people get diarrhea. Headaches are also a common complaint, and sexual dysfunction is also very prominent, and it can be a reason that people discontinue medication. So it's important to think about that as well. We also get weird side effects like increased sweating. Some people do become more agitated, and there is still the black box warning on antidepressants. So there were some controversial findings about antidepressants in general. It started out with just SSRIs, and now it's been broadened to include every single antidepressant. There is a controversial finding that these medications were associated with increased suicidal thinking, not increased suicidal behavior or completed suicidal thought. The studies were not done very well at all, but the studies did lead to a black box warning, which means that when we prescribe these medications, we have to monitor very closely and check in on our patients weekly as we're increasing the dose or changing to a different medication. This point about QTC, that's a detail that I don't need to go into unless there are questions about it, and I'm happy to answer it, but in the interest of time, I'll move on. Other odd issues relate to increased bleeding problems. So this is something that we need to think about for girls who are prescribed this medication. So in case there's already problematic issues around having periods, then we need to be prepared for the possibility that these agents will worsen flow, and that is because of the action on platelet function. So there are other serotonergic agents that have dual activity. So the serotonergic noradrenergic reuptake inhibitors, those are duloxetine or Cymbalta, and venlafaxine or Effexor. And these are really helpful when we're treating anxiety in the setting of pain. The side effect profile is similar. Again, sweating, GI issues. Sometimes people can have increases in their blood pressure, not too significant, but if there is a bump in the blood pressure, then we need to track that. These medications are more often associated with what's called discontinuation syndrome, which means that if individuals skip a few doses, then they're not going to be feeling so good. And so it's really important that the daily dosing of these medications is consistent. They've also been associated with seizures in high doses, so like in the setting of overdose. Mirtazapine, the alphabet soup here, is a noradrenergic specific serotonergic antidepressant. And that basically means that it acts at a couple of different receptors, adrenergic receptors as well as serotonin receptors. So this doesn't increase the amount of serotonin in the synapse. This acts directly at serotonin receptors. The bottom line is that it takes effect much more quickly. So I happen to like this medication because its effects are much more rapid in terms of onset, and it actually has a side effect profile that is often relevant for my patients, especially in terms of being sedating. Again, kids who have trouble sleeping do really well on this medication. It does cause weight gain, and it can cause metabolic syndrome. And on very rare occasions, it can cause a decrease in white blood cells. So this medication actually requires lab work. So for individuals who don't tolerate lab draws, or blood draws, this is probably not a good option. So I just needed to point that out. So now we're shifting to medications that treat the stress response. The medications that we were discussing focused on treatment of anxiety. These sets of medications target the stress response circuitry. So clonidine is an agent that works directly on the brain circuitry. It works centrally, so it actually targets the circuits that control the fight or flight response. And again, the alphabet soup just suggests the designation of which type of adrenergic receptors are targeted. It comes in immediate release formulations as well as extended release, and the immediate release requires at least 3 times a day dosing, And the reason for that is that there's a risk of rebound hypertension. So when we use this medication, it lowers the blood pressure, which is appropriate for addressing the stress response. But if you go too long without your next dose, then you can have a rebound, a spike in your blood pressure again. So it's important to keep a steady level in the bloodstream. So missing doses is problematic. Which is why I prefer the other medication that works on the stress response circuitry, and that will be our next slide. Because it's now made in an extended release formulation, that is my go-to option for clonidine if I want to use clonidine. I often don't want to use clonidine just because its side effect profile is more problematic than its cousin, which is guanfacine. So guanfacine is basically the next generation of clonidine. It's more selective than clonidine, which is good, has a better side effect profile, which is good, and it has a longer half-life, which is also good, relative to clonidine. There is an extended release version. It is used to treat ADHD. This version of guanfacine is known as Intuniv. But it is actually still effective in treating the stress response. And the benefit of using extended release versus immediate release are not great. It's convenient, once daily dosing, but in terms of efficacy, it doesn't really do much better than using regular guanfacine twice a day. And it's also more expensive. So my tendency is to prescribe guanfacine and use it twice a day. So guanfacine immediate release, I should say. Oh, and it's important to educate patients and caregivers about the importance of staying hydrated with these medications. Again, these are medications that have been used to treat blood pressure or to lower blood pressure. You don't want the blood pressure to go too low, so it's really important to stay hydrated. So that helps with the possible side effects related to low blood pressure, and it also helps with the side effects that are a little odd, and that's an experience of dryness, so drying out the GI tract, which causes constipation, and also drying out eyes and mouth as well. Then there are these agents that have GABA in their name, which is why I have GABAergic in quotation marks. They don't actually act at the GABA receptor. And also in quotation marks is maybe. So these aren't our go-to options for treating anxiety, but they can potentially be useful as augmenting agents. So when a medication has been started that is somewhat effective, but it's not doing enough, then we can think about adding these medications, these GABAergic medications. They actually work at voltage-gated calcium channels, so they act everywhere. So it's kind of a shotgun approach to modulating neuronal function. So it has an impact on all sorts of neurotransmitters, glutamate, norepinephrine, substance P, so peptides in the brain. But what's nice about these medications is that they are renally excreted, they're not metabolized by the liver, and so there's minimal drug-drug interaction again. And they happen to be FDA approved for young children, which is a big deal for child psychiatrists in particular, because we have to do a lot of off-label prescribing, which means that the FDA has approved medications for use in adults. They haven't bothered to test these medications in children. There just isn't a big enough market to motivate them to do that. So they don't bother to test these drugs in kids unless there's a market for it. So we have to presume that being safe in adults means that there is a level of safety for use in kids, and so we just do very close monitoring of these medications that are not FDA approved in kids. Fortunately, these GABAergics, gabapentin and pregabalin, are FDA approved for use in kids. So even though there are few drug-drug interactions, there are some problematic side effects. These include blurred vision, edema or swelling of the limbs, some potential wobbliness or tremor. And again, this is related to the fact that it's a shotgun approach. So every neuron in the brain is going to be affected by these agents. So neurons, not just in the cortex, but in the cerebellum, everywhere in the brain is going to be affected by these drugs. And so, not surprisingly, we see symptoms that are related to like cerebral dysfunction, cerebellar dysfunction. Sorry. And then I've saved neuroleptics for last, in part, again, because they don't treat anxiety. They treat behavioral dysregulation, mostly in the setting of stress response. The FDA has approved 2 medications for this purpose, and especially in the setting of agitation in autism. The 2 medications are risperidone or Risperdal and aripiprazole or Abilify. Risperdal is associated with significant weight gain, aripiprazole not so much, but both can cause metabolic syndrome or changes in blood sugar and cholesterol levels. So some individuals can't tolerate these medications. If that's the case, then quetiapine or Seroquel can be helpful. Not only does it treat behavioral dysregulation, it actually has anxiolytic properties or anxiety-reducing properties. So it can be a backup agent if Risperdal and Abilify aren't effective. Then we've talked about things to use. I want to highlight medications that we should avoid using. Those are the benzodiazepines and the antihistamines. I say that we shouldn't use them because they actually don't treat anything. They mask symptoms. That approach bothers me. I don't want to mask a situation. I want to treat a situation. So philosophically, it's problematic to use these medications, but also functionally it's problematic because these medications are associated with a higher risk of delirium, disinhibition, and dependence. So the 3 Ds. Disinhibition basically means that, if you're trying to treat agitation, you actually can make agitation worse. Instead of using those medications, these tend to be used on an as-needed basis. As an alternative, again, propranolol and gabapentin are preferred. And I mentioned the importance of monitoring. So when we use these medications, it's important to check on how they're having an impact on physiology. For some medications, it's more important than others. For the serotonergic agents, it's good to check electrolytes at least once a year if we can. If we can't, then there are ways to monitor electrolyte levels clinically without having to poke. But if we are able to draw labs, then we should do so at least once a year. As I mentioned, the SNRIs can elevate blood pressure, and so it's good if we can check blood pressure at clinic visits. And one of the SNRIs, duloxetine, can cause liver enzyme changes, and so it's helpful to check liver function tests, LFTs, liver function tests, if you've prescribed duloxetine. And then again, I mentioned that mirtazapine can be very rarely associated with these drops in white blood cells, so it's important to check the CBC, or the complete blood cell count, as well as glucose and cholesterol because of the metabolic syndrome. So again, I mentioned that the focus was on pharmacotherapy, but it's important to think about pharmacotherapy in the broader context of intervention. And I want to emphasize the point that when we're treating anxiety or treating a stress response, we shouldn't just use medications. Medications should be used if the other interventions still have residual symptoms, that they're not taking care of every component of the stress response or anxiety symptoms. So it's important to have these other interventions occurring simultaneously or to precede pharmacotherapy, I would say. And so I wanted to focus on a specific type of psychotherapy, which is actually behavioral therapy. It tends not to be seen as psychotherapy, but I will include it here. And the types of behavioral therapy that we tend to recommend are cognitive behavioral therapy, or CBT, exposure and response prevention, or ERP, and then relaxation techniques. So CBT has the most extensive evidence base of these behavioral therapies. It tends to be problem-focused and goal-oriented, and addresses cognitions, the C of CBT. And it tends to involve skill building, so it requires homework, and that the sessions with the therapist are basically training sessions that include the expectation that the individual will work on the homework between sessions, and that the subsequent session reviews how that homework has gone and then adds on a subsequent skill. So again, just in thinking about how CBT works, it's a very collaborative approach, it's educational, and it's meant to be empowering. And the target population, I say here, it is in grade school. We need to think about what that means developmentally. So what we're talking about is individuals of a developmental age that is equivalent to being in grade school. There are some CBT protocols for younger kids, so the lower grades of elementary school. Coping CAT is one of the more common ones. It's a very popular one. And then Facing Your Fears is a program developed in Canada, I believe, that targets older or developmentally older individuals. And CBT often involves ERP. They can go hand in hand, especially for anxiety disorders like specific phobias. So just to clarify what exposure and response prevention is, it's basically gradual desensitization. So again, hence the term. So you expose to something that causes an aversive reaction very gradually, with the goal of extinguishing the response. Most of the studies that have looked at ERP have been done on OCD, which back in the day had been classified as an anxiety disorder. It isn't anymore, but it used to be. And there are lots of similarities to anxiety disorders, so this is why I'm including it here. And these studies have compared ERP to treatment as usual for anxiety management, and have found that ERP is more effective. So I mentioned phobias, and the problem with ERP is that when you start engaging in this intervention, you will likely elicit an extinction burst. This is hard work. So you are likely going to have a greater reaction to the stimulus because you're trying to change a behavior. So you kind of have to batten down the hatches with this one. But if you can get through the extinction burst, it's a very, very effective intervention. And then we talked about, or I mentioned relaxation techniques as a form of intervention. So things like MBSR, mindfulness-based stress reduction, guided imagery, biofeedback, and even progressive muscle relaxation. These can be very helpful. Again, this requires a level of calm that, if we're talking about a fight or flight situation, it's not a most effective intervention. So, I'm picking up on social cues. So in summary, yeah, it says sum up, I'm summing. So in summary, anxiety disorders are quite prevalent. There are a broad spectrum of symptoms. It's really, really important to think about them early so that we can intervene early. And treatment is quite broad. It does include pharmacology as well as psychology. And thank you very much.